Thank you, Surabhi. So it's a pleasure to be part of this interesting session, which is going to discuss some new um, few new concepts in glaucoma. Basically, we are reiterating what uh, we as glaucoma specialists usually would like our patients to have, which means quality management of glaucoma. And we're going to emphasize quantity over quality. And I'm glad that we have two eminent speakers with us, Dr. Shibal and Dr. Vanita. I will introduce them a little bit more in detail after a bit. And what we are looking over here is basically, we're talking about glaucoma diagnosis, where we'll try and focus on looking beyond IOP. We'll then talk about holistic management of glaucoma. And we'll also look at how tafluprost can add value to our management. So when we're looking at beyond IOP, we will be looking at the other factors that we feel as glaucoma specialists have more importance in the management of, in the diagnosis of glaucoma than just IOP. We'll explain why quality of IOP control is important. And we'll also talk to you about how adverse events can actually impact compliance. We'll discuss with you some of our experience with tafluprost in glaucoma management. When we're talking about quality of IOP, we will be talking not just in terms of the single IOP reading that you get, but also how it matters when you measure IOP many times, how fluctuation can impact visual field loss, how having a red eye or an irritable eye can make your patient actually stop using medications, and how non-adherence is one of the important factors when you're talking about patient compliance and how that makes things difficult for you. I would also like to give you an opportunity to ask us questions, and we will have at least 10 minutes for panel for question and answers that come to us from you at the end. And I would strongly recommend that you put your questions to us, and we'll be very happy to do our best to answer them. It's my pleasant privilege to introduce Dr. Vanita Pathakre, who will be speaking to us later today. She's the Director Glaucoma and Senior Glaucoma and Cataract Specialist at Center for Sight in Hyderabad. She has over 17 years experience in different parts of the world. She was consultant ophthalmologist in UK for over 14 years, and after which she worked at LV Prasad Institute. She has received many awards and recognitions, including the first Indian glaucoma specialist to perform NIGS in angle closure disease, the first Indian glaucoma specialist to use a Kahoot dual blade, and she has won many awards for her presentations in numerous scientific conferences and meetings. She's been invited faculty for many national and international conferences and webinars, and is extensively published. And we look forward to hearing from her a little later. It's also a pleasure to introduce Dr. Shibal. She's Senior Consultant at Fortis Memorial Research Institute in Gurgaon. She is been specializing in glaucoma and ocular surface disease for a long time. She also has extensive international experience, having worked in in at least 3 continents that I know of. She's also very academic and is the executive editor of the Journal of the Current Glaucoma Practice, which is the official journal of the International Society of Glaucoma Surgery. She's the editor-in-chief of Clinical and Experimental Vision and Eye Research. She's the founder-director of Medical Language Editing Service, and she writes extensively. I'm sure many of you would have come across her textbooks at some point of time or the other. She has also served as clinical director MedFlow Eye Care Leaders in North Carolina, where she worked towards incorporating clinical pathways and evidence-based medicine into ophthalmology EMR. This is something I didn't know, Shibal, by the way. She's also a consultant to Cantor Health Eye Care Leaders towards setting up their AI and big data-based healthcare analytics platform. She was formerly head of academics and research at the I7 Hospital in Delhi, and we will be hearing from her a little later. But to set the ball rolling, I will start now by talking about glaucoma diagnosis, what you need to look for beyond IOP. And the reason we talk about this again and again is because historically, increased IOP was considered to be glaucoma, and glaucoma was considered to be increased intraocular pressure. And unfortunately, this is still a mindset which prevails among many people. So before we go further in here, let's talk about what is normal IOP. And when you look at the distribution of intraocular pressure in a population, this is what it looks like. You will see that most people are bunched up around the middle. Some are bunched up on the left side and some are bunched up on the higher side. And typically the ones on the higher side, there's a slightly longer tail on this side. So when you look at the normal values for any disease, the way it is calculated is you look at the mean value and you look at 2 standard deviations on either side. And this actually includes about 95% of people. So by definition, 2.5% of normals are going to have a pressure of more than 25 millimeters of mercury. And these are statistically normal pressures if you're talking about it. So by definition, 2.5% of normal people will have an IOP of more than 21 millimeters of mercury. Therefore, raised intraocular pressure alone does not imply disease. It could well be just a statistical outlier. And I'll share with you some of the data from the Baltimore Eye Survey from which a lot of this IOP has come out. And what they found is that 59% of their POG patients in the Baltimore Eye Survey done in the US had intraocular pressures less than 22 millimeters of mercury. Look at 3 studies from India now. In the Urban Comprehensive Eye Survey, 53% had intraocular pressure less than 21. In APED, 67% of people had IOP less than 22. And in the Chennai Glaucoma study, 68% of patients had intraocular pressure less than 22 millimeters of mercury. So if you look at only intraocular pressure to diagnose glaucoma, you would land up missing between half and 2/3 of your glaucoma patients. And in fact, this is the sensitivity and specificity of intraocular pressure in the Beaver Dam Eye Survey and in the Baltimore Eye Survey. And this is the same figure for the Chennai Glaucoma study. And what it basically tells you that at the IOP of 50% there, you are going to be missing a whole bunch of glaucomas because your sensitivity and specificity is just about 47% and 92%. Using only this criterion, only 1 in 16 patients with an IOP of more than 21 will actually have glaucoma. Keep in mind that even if you look at IOP of more than 21, both the Baltimore and the Chennai Glaucoma study, just about 10% of people who had a single intraocular pressure of more than 21 millimeters of mercury had glaucoma. So using IOP alone, you run the risk of 2 things. One, you run the risk of not diagnosing between half to 60% of your patients. And 2, you run the risk of misdiagnosing a lot of people who actually have ocular hypertension instead of glaucoma. So what is the actual role of IOP? The absolute value is not diagnostic, and that is why it's no longer part of our diagnostic definitions. Keep in mind that higher intraocular pressures are associated with a higher risk of glaucoma, but a significant number of patients who will have normal presenting IOPs when you see them. So what should you look for beyond IOP if that is the case? So keep in mind just 2 things. One, that our new definition tells you that glaucoma is a progressive optic neuropathy. So if it is an optic neuropathy, you definitely need to look at the optic disc because that's the only way you will be able to detect a neuropathy. The second thing that you need to keep in mind is how do you classify glaucoma? You classify it as open angle glaucoma or angle closure glaucoma, which means you need to do gonioscopy because without doing gonioscopy, you cannot even say whether an angle is open or closed. And the third thing that you look at is you classify it as primary or secondary. So you need to rule out any secondary causes of glaucoma before you finally decide that this is glaucoma or not. So optic disc, angle, and secondary causes. These are the 3 things which are absolutely essential for you to diagnose glaucoma. When you're diagnosing, the aims of evaluation are, of course, diagnosis, but also what all you need to look at in terms of initiating treatment and how you plan to follow up the patient. And this is something you should keep in mind. So you need to do a detailed history, visual acuity, slit lamp evaluation, and visual field assessment because all these are important. I'm not going to talk too much about history beyond saying that most glaucoma is asymptomatic. Most primary glaucoma is asymptomatic. So don't expect your patient with angle closure to come to you with symptoms. And also it's useful to ask for family history because that might give you a hint as to what type of disease you're looking at. When you look at the minimum standards for glaucoma evaluation, slit lamp evaluation is one of them. And a careful slit lamp evaluation gives you a lot of information. Conjunctival congestion could tell you that it's an acute angle closure or a secondary glaucoma. Allergic conjunctivitis could probe you to ask the history of steroid use. And definitely you could see drug adverse events in your patients who are already on glaucoma medications. So this is something that is really important. It's also important to take a good look at the cornea. corneal edema, we know, is associated with a lot of high intraocular pressures. But then if you're seeing a very localized corneal edema like this would straight away point to either a localized penetrating trauma or something like that, or a viral etiology. If you see something like this, keratic precipice, you know that you're dealing with a uveitic glaucoma, and you know that you need to keep this in mind when you think in terms of treatment. If you see a Krukenberg spindle, again, you have your diagnosis right away. If you see something more gross like sphincter tears, you know that's trauma. There's transillumination, which could again hint towards pseudoexfoliation or pigmentary. And you could have an accent field anomaly, which would tell you that could well lead to a very aggressive form of glaucoma that may be difficult to manage. Keep in mind, a careful iris evaluation will help you to look for dubiosis. You may need to look at it under high magnification. And sometimes this can be fairly subtle with the sort of diabetes pandemic that we have in India. This is something that you need to look for closely. Antechamber presentations like this will straight away give you the diagnosis. But don't forget that any of these can be more subtle than what I have shown you over here. So a careful evaluation will always help you to rule out a secondary cause and will guide you to the primary cause. Now, gonioscopy is something which unfortunately is not done as often as it should be. Very often we tend to use the Van Herk system and say, okay, based on this, we'll classify it as open and closed. Keep in mind that this is not a surrogate for gonioscopy, but this should also be done in everybody, because if it is positive, you definitely need to put in a gonioscope. If it is negative and you have a busy practice and the patient does not have glaucoma and is not a glaucoma suspect, you may be able to get away without performing gonioscopy on this patient. What are the minimum standards of evaluation when you're doing gonioscopy? As per the CGIC guidelines, you should ideally use a gonioscope that permits indentation, which means you could use a Sussman or a Zeiss, because indentation is very useful when you're looking at angle closure glaucoma. Testing conditions for gonioscopy are also important. So it's important that you do gonioscopy first in an undilated pupil, use a slightly dark or dimly lit room, use a short slit which does not fall on the pupil, and record the structures that you see. Take a look at the iris contour, take a look at trabecular meshwork pigmentation, look for K. And in India, we actually define angle closure as non-visibility of the pigmented trabecular meshwork for more than 180 degrees. So this is the bare minimum that you would need to look at on gonioscopy. And whenever you see a narrow angle, if you use a gonioscope that permits indentation, you look at the arrow on top, you can see that the angle looks closed. But the moment you indent it open, you can see that you can actually indent it open, and you can see peripheral anterior K there. And this is somebody who would actually have primary angle closure and is therefore need a YAG peripheral iridotomy. So careful gonioscopy is really important for you to classify disease, decide on treatment, and follow up the patient. Gonioscopy is not only about angle closure. There's a lot of open angle glaucoma where you might see features like an angle recession, which would straight away tell you that this patient is at greater risk of progression, and would also tell you what the reason for glaucoma is there. You can always compare that quadrant with the quadrant in the other eye, and that will tell you that this is much wider, and there definitely is recession here. It sometimes helps you to solve mysteries. For example, this 53-year-old man who had undergone cataract surgery 6 months ago and had uncontrolled glaucoma since then. You put in the gonioscope, the cornea is a little hazy, but you can see this capsular tension ring sitting in the angle. So even if you had done a trabeculectomy in this patient, you would probably have landed up with a decompensated cornea unless you address this. So we removed the ring, we did a trap, and after that he did fairly well. The other important thing that we spoke about was the optic disc assessment. And perhaps this is really, really critical. And the minimum standards that the CGIC suggests for this is that you use a slit lamp biomicroscope using a 60 diopter or 90 diopter lens. In expert hands, a direct ophthalmoscope is acceptable, but I think in this day and age with COVID all over the place, none of us really wants to get that close to our patient. So it's a good time to transition to using a 60 or 90 or 70 diopter lens. The critical steps in assessing the disc are the 5 R's, which are basically you observe the scleral rim to identify the limits of the optic disc and the size. You identify the size of the rim. You examine the retinal nerve fiber layer analysis. You examine the region of peripapillary atrophy, and you look for retinal and optic disc hemorrhages. So when you are identifying the scleral ring, this is the ring. That little whitish, slightly elevated band, that is the edge of the disc. And it's important for you to classify the disc as small, medium, and large, because your cup size is based entirely on the size of the disc. And it'll give you an idea of how suspicious you need to be of a large cup. And this is because, in general, the number of ganglion cells exiting the disc is relatively constant. It's about 800,000 to 1.2 million. And disc size varies much more than this. Disc size varies by almost 600% between the smallest and the largest, while the number of ganglion cells is relatively constant. Next, you identify the size of the rim. So when you look at the size of the rim, there are two things that you can do. You can either look at the rim contour or you can look at the rim color. And most of us, the reflex is to look at the color because that's easier to identify. But it's important that you look at contour, and this is where we have the edge of the disc marked, and that's where you have the edge of the rim marked. When you look at color, you would quickly draw this somewhere here. But once you look at the contour, and that's the vessel bending there, you notice that it's a much, much larger cup than what you would have done by just looking at the color. And this is something that is important because now you can see almost an inferior notch there, and you know that this is somebody with a small disc with significant glaucomatous damage. The other thing that you would look for when you look at the rim is identifying the isn't rule. Does this meet the isn't rule or the ISNT rule, which says that the inferior rim is generally thicker than the superior rim, which is thicker than the nasal rim, which is thicker than the temporal rim? There are two sub-rules to this. One is that the temporal rim is always, there is no part of the optic disc which is of the neuroretinal rim which is thinner than the thinnest portion of the temporal rim. So if you see localized thinning anywhere which is thinner than this, it's very likely to be glaucoma. This is not a 100% rule, but this is an important, if you see somebody with an ISNT rule which is true, it's unlikely that they have glaucomatous optic discs. Look, when you start looking at contour, you notice that there are some, you might see localized narrowing there, which is suggestive of an inferior notch, of an incomplete notch. Complete loss of the rim there would be a complete notch. And unless you look at the neuroretinal rim carefully, instead of looking only at the optic disc cup to disc ratio, this becomes problematic. You can also get concentric thinning of the neuroretinal rim, where you can see the vessel is bending here, 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 and this is an almost completely cupped out disc. Cup to disc asymmetry is the other important thing that you need to look for. And if you look at the image on the left, you can see that that's a fairly large cup. You're seeing an inferior disc hemorrhage and a nerve fiber layer defect, and you compare that with the fellow eye, which has a small cup. But whenever you look at cup to disc asymmetry, always also rule out disc size asymmetry. So this is a disc pair, and I'm just showing you the vertical and horizontal diameters. And you can see that one disc is substantially larger than the other disc, and that is the reason for the cup to disc asymmetry. So having a handle on the disc size is an important feature of trying to assess what sort of, whether the asymmetry is true or not. Always assess the disc color. A pale rim is unusual in glaucoma unless you've had a very high intraocular pressure spike, and a disc pallor should always have, you should have a high index of suspicion. And I'm going to share with you this example where you see this, both eyes have fairly large cups. The rims actually look fairly okay, but this shows some pallor compared to this. And when you image, you see a classic defect respecting the vertical midline, and the patient had a pituitary adenoma. So keep in mind that any pallor should be looked at with suspicion, especially when it is associated with any decrease in vision which you cannot explain. The next important part is to examine the retinal nerve fiber layer, and this is best performed with a red free light. What you need to look for, you need to look to see how bright is it. You need to look for striations. You need to see whether you can see peripapillary blood vessels and whether you can see diffuse or localized nerve fiber layer loss. So typically when you look at this, this is what you would see. You would see a bright zone superiorly and inferiorly corresponding to the thick nerve fiber layer bundles, and a dark zone in the region of the of the macula. And this is the typical pattern: bright, dark, bright. When you have a nerve fiber layer defect like you have over here, you would see bright, and then you see a dark band there, and the vessels become a little bit more prominent in that area, and you would see bright again. So this is a disc I showed you earlier. There was a classic superior notch there, and you can see a large RNFL defect over here. And you can see that the bright pattern is immediately, you can see the contrast there, and it is easy to assess. So whenever you have localized damage, you can see, you're very likely to be able to see retinal nerve fiber defects. They're best seen with a red-free filter, or if you can take a red-free photograph, that makes it even better. The next thing that you need to look for is look at the region of peripapillary atrophy, and basically that is this area here. I'm not going to go into this in too much detail, but careful recording of this will help you to look for progressive damage. The presence of thinning of the nerve in the region of the peripapillary atrophy again helps you to localize damage. And the last R that you would look for is retinal or optic disc hemorrhages. So an optic disc hemorrhage actually requires careful evaluation. You might think that this is not something you're going to miss, but they can be tiny. And if you don't look for it, you can miss it. They often disappear within 1 to 3 months, and it could indicate progressive damage. So this could be the hint that this patient that you're seeing needs more aggressive treatment. So here you have a disc hemorrhage, which is fairly large and adjacent to the disc. So the critical steps in assessing the disc are the 5 R's. So look at for the scleral ring, look for the nude retinal rim, look for the retinal nerve fiber layer, look for peripapillary atrophy, and look for optic disc hemorrhages. So when you look at the scleral rim, what do you need to do? You need to measure the vertical diameters, or you need to describe it as small, medium, or large. When you look at the rim, see, is the ISNT pattern followed? Is there localized thinning? Is there pallor? When you're looking at the retinal nerve fiber layer, document whether there's an RNFL defect. When there is peripapillary atrophy, is there peripapillary atrophy? Is there zone alpha or zone beta? Document that. And is there an optic disc hemorrhage? Yes or no. And how should you document this? Ideally, draw it or take a photograph. They are both very, very valuable when it comes to follow-up. If not, at least answer these questions that I put on the right. What's the size? What's the rim like? What's the NFL defect? What's the NFL like? What's the peripapillary atrophy like? And is there a disc hemorrhage? So you might ask me, well, we never even spoke about the cup to disc ratio. And really speaking, the cup to disc ratio has very little value because it is dependent entirely on disc size. So without the disc size, your cup to disc ratio has little value. And there's a lot of variability between two people when it comes to describing a cup to disc ratio, even within yourself. It's more important that you talk about the other parameters and the cup to disc ratio. We switch gears now to talk about how do you assess damage, and that is essentially with a visual field. Because the visual field is essential to diagnose functional damage, which is what we are worried about. And it's also essential for us to assess glaucoma progression. And what do you need to do for this? You need to look for a test which gives you good threshold testing, a good database, and a good progression software. Keep in mind that there are a lot of perimeters available out there which will map out a visual field defect for you. But you have to ask yourself, how good is that normative database? And if I'm going to follow up this patient for 10 years or 15 years or even for 5 years, do I have good quality progression software with which I can detect progression? Most of us can diagnose glaucoma with the visual field, but we cannot effectively manage glaucoma without managing visual field progression. Keep in mind that whenever you look at the visual field, also assess whether it matches your disc findings. For example, here you have a biaquate scotoma, which sort of matches the superior and inferior loss. And you can see diffuse NFL loss on both sides here. Or somebody like this who has an early little bit of thinning there, and that matches your little inferior nasal step. Or you have somebody like this, a 35-year-old man who complains of headache, and he comes to you with a field which looks like this, and immediately you feel that you need to send him for clinical evaluation. You repeat the field and it disappears. So any field defect needs to be repeatable before you jump up and down and decide that I need to do something for this patient. So you save this patient an MRI by just making sure he did the field, repeated the field again. Look for a learning curve, because visual fields are not easy to do, but patients do learn how to do them. Rule out other obvious causes which might interfere with or which might help you with your diagnosis, like certain central retinal vein occlusions or proliferative diabetic retinopathy. Look for macular pathology, because that has treatment implications with prostaglandins. Look for field defects which may be related to macular pathology, and this is typically a problem in myopes who very often have field defects, and it's difficult to figure out how much of it is because of the myopic change and how much is because of the glaucoma. In that situation, taking a good disc photograph and having good visual fields is helpful. So this is a patient with a family history of glaucoma, diagnosed elsewhere to be a glaucoma suspect, had an intraocular pressure of 20 millimeters of mercury, and we were considering getting a few IOPs checked and then deciding on treatment. This is what the disc looked like, fairly healthy, and really didn't match that visual field that we saw there. And when you do a little bit more detailed retinal evaluation, you see an old vessel occlusion there. You can see scars there. And this is what was contributing to the field defect. So you need to do a careful evaluation. You need to make sure that whatever your clinical findings are actually match what you're seeing in the patient. So when you look beyond IOP, you need to classify the patient as primary or secondary. You need to classify the patient as open or closed. You need to do a good optic disc evaluation and gonioscopy. In fact, for you to rule glaucoma, you need to do a complete ocular examination. Thank you, and for your patient listening. And I request. So our next speaker will be Dr. Shibal, who's going to speak to us on a holistic approach in the management of glaucoma. Over to you, Shibal.
Good morning, everyone, and it's such a pleasure to be here. Thank you so much for having me, and it's such a privilege to speak after Dr. Rani has already set the stage and spoken to all of us about how IOP is not central to glaucoma diagnosis. And before Vanita walks us through what is new to the glaucoma armamentarium in terms of medication, I'm going to speak of the bridge between the two. How do we look beyond the IOP in our patients, and how do we not use the IOP for diagnosis, but also in our management? How do we look at intraocular pressure, because that is the only modifiable risk factor, but how do we look at it in the perspective of the entire individual as a whole? As we shift more and more from evidence-based medicine to precision-based medicine, it is increasingly important to remember that your patient is just like you. And if you've not had, I'm sorry, but my slides don't seem to be moving. Yeah, got it. So in case, if you've not had a set of glaucoma investigations done for yourself, I highly recommend you do them. And you'll be much more empathetic when you need to order a repeat fields, as Dr. Rani just spoke of right now, that all fields must be repeated before they're taken as valid. We presume when we start off treating glaucoma that nothing really happens to the patient in glaucoma, that the patient is asymptomatic until almost the end when the patient goes blind. That is true for glaucoma that has not been managed. But the minute you start talking glaucoma, that is when things start going wrong for your patient. And that's critical to remember. Remember, your patient doesn't really, unless it's acute angle closure, doesn't really come to you with symptoms or comes with the presumption that he or she might have glaucoma. Glaucoma is diagnosed when they are visiting you for other concerns. And remember, glaucoma, the word kalamotya, is scary. It's scary for the doctor, it's scary for the patient, it's scary for the caregiver. The fear of blindness is real and present. In your mind also, I think, in all our minds, I guess, even though not so many of our patients do eventually progress to blindness, we've all been geared to associate glaucoma with blindness. And part of that is because we tend to scare our patients into compliance rather than talk to them into compliance. And that's critical to remember, because quality of life changes are across the severity continuum. So somebody who comes to you with ocular hypertension also has quality of life changes, and that is critical to remember. What really happens in glaucoma in terms of quality of life is that the first decrease in the quality of life of the patient happens the point you start discussing glaucoma with the patient. When you start talking in terms of them being a glaucoma suspect, the duration between the testing and the results, and finally being told that you have glaucoma can be extremely scary. And that itself causes an immediate drop in the quality of life of the patient. When you start treatment, again, remember, the patient of glaucoma is asymptomatic only until the day you intervene and start making them symptomatic by taking care of them. Starting glaucoma therapy is an immediate drop in the quality of life of patient, even if they don't come to you saying, I have a red eye or my eyes are irritated, because the act of remembering that you have glaucoma and consequently must use eye drops every day for the rest of your life is enough to rattle almost anyone. I don't know how many of you have had these patients, but eventually once you've had the patient in your care for a long duration, the patient doesn't see any incremental benefit to your treating them. A lot of patients do a reverse therapeutic trial for themselves. Simply stop glaucoma medication for a while and see if that's affecting their vision. And if it doesn't affect their vision, which it will not, they come back to you with the presumption that the glaucoma treatment was not really required. And at that point, if you are to talk to them and talk of continuing glaucoma medication, Remember, you have to battle a serious God complex there. The patient was asymptomatic without medication. You started them on medication, they became symptomatic. They stopped the medication again. They didn't see any perceivable difference in their vision throughout this start and stop of treatment, but they did see a start and stop in their side effects that they were having from your medication. How do you then tell that patient to continue to take your medication? Those subset in this graph in red, where they actually have physical quality of life related concerns because of vision loss, are the patients who are on the other end of the glaucoma spectrum, the ones that we struggle with in terms of preserving vision. But majority of our practice is going to be in the green-orange zone, and it is for them that you must critically evaluate what you are choosing to put in their eye and why. A lot of us will err on the side of undertreating because we're scared of quality of life concerns. A lot of us will choose a milder agent when we are treating these patients, and it's critical to make that balance between the quality of life and the visual function preservation, because the quality of life associated with visual function is also real and present. Remember, the target IOP now has two endpoints, not just the one: visual function as well as the quality of life. Never here is the IOP defined, like Dr. Rani pointed out so eloquently in that beautiful Gaussian distribution skewed to the left, that IOP is a number which has to be related to 21. The costs of quality, the cost of IOP reduction in terms of the quality of life costs have to be taken into consideration, because what you are looking at is the range of IOP at which the disease progression does not affect the patient's vision-related quality of life. And that should also not impact the quality of life of the patient, and that the burdens and risks of therapy have to be balanced at each time point against the risk of disease progression. Now, this evaluation, therefore, is extremely dynamic. It changes with time, and it has to come from a serious communication between you and your patient. Remember, all of us, glaucoma is almost becoming like a number game. There's so many numbers that we can focus on, whether it is IOP, and those of us who are really cognizant of fluctuation, the peaks, the fluctuation, the dips, the decibels in your field changes, the microns on your NFL thickness. Some of us also in practices which are larger are very cognizant of the economics of glaucoma therapy. The numbers that we are sometimes not looking at, which are as important, are the quality of life costs to the patients. The dropout rates, the patients who will, just simply stop using their medication, not only just because of adverse events, but also because they see no perceivable benefit to using the medication you have talked of. And remember, the game changer in glaucoma is compliance and adherence. That is because we've seen all kinds of developments which are dramatic. We've transitioned from pilocarpine and timolol to now prostaglandins and MIGs. And yet the rates of glaucoma blindness over the last century haven't changed. It's because the game changer in this one is the long innings of glaucoma, which was asymptomatic, made him asymptomatic by treatment, and consequently persistence is so important to clinical outcomes. So what is it that we are looking at? What constitutes a holistic approach, a quality-based IOP control approach? You cannot ignore the premise that IOP has to be decreased to manage glaucoma. So mean IOP reduction is extremely important. Response rate is a corollary to that. If a patient is non-responsive to a drug, of course, that drug is not one that you will consider. And of course, the only way, again, banking off Dr. Rani's lecture here again, is long-term IOP control and visual field stability. You have to have functional proof of the drug working, and the only way to do that is the visual field progression. And IOP control is only a surrogate for that, because visual field changes are not immediate. 24-hour fluctuations are extremely important in the same regard. But the other thing that is equally important is to remember that all of this has to be weighed against patient adherence, compliance, and persistence, because that is what is going to result in long-term quality IOP control. So how do we evaluate the efficacy and response of a drug that we choose for our patient? So what are the IOP attributes of the first choice drug that you will use for your patients? Of course, efficacy measures are very, very clear. You have to look at the percentage IOP lowering, not only if you're starting treatment in a patient, so treatment-naive patients, of course, and there are times when you will have to switch treatments, and it's extremely important to remember what is the percentage IOP lowering in when you switch treatments or when you add a drug to another one. Of course, diurnal fluctuation is as important because we remember that the drumbeat effect of IOP that is not controlled at night damages the optic nerve almost as much, if not more, as the absolute value of IOP. And of course, then there is the consistent long-term efficacy of the medication, which will only be measured by visual field stability, and your IOP control over time will only be a surrogate for functional visual damage. Keeping all of this in mind, there really isn't much of a debate to prostaglandins being the first choice always. And if you were to look at all of the prostaglandins that are available today to us, they almost have a similar mean IOP lowering, at least in patients that have in real world experiences with patients with POAG, ocular hypertension, as well as PACG. You will have everyone speak to you of how one prostaglandin is superior to the other and why. But what is critical to remember that the efficacy is almost similar across the class. There will be one which will give you an additional 1 or 2 millimeter mercury lowering, but remember that could also be your test-retest variability. Every single time that you measure IOP, you're not measuring it at the same time. It's not the same observer. So with efficacy being almost similar across class, what then is the differentiator? Of course, response rates. A drug that is not effective will have to be changed for another one. And the side effect profile, because the glaucoma number game is a really long innings. If you are looking at the clinical lifespan of a patient who walks into you in their, maybe 50s, you're looking at about 30 years of glaucoma medication for that patient. And the side effect profile, not just the adverse event profile, which is like immediate and sudden and big, but the side effect profile is going to take forever for you to evaluate. Remember, most of these drugs, when they are being evaluated, have a much higher incidence of side effects than you see in clinical practice. So you'll turn around and say, oh, I didn't see like 30% incidence of hyperemia with this particular drug in my clinical practice. Why did it reflect so much in the clinical trial that was put out? That is because in the real world, we are not asking the patient for side effects. Remember, patients are hesitant. They will not discuss their problems with you unless you provide for them, one, an environment that encourages conversation, and two, unless you ask them direct questions. Is this drug giving you a problem? Only then will you be able to elicit side effects sometimes. And those, of course, are the tip of the iceberg. The ones that come to you and say, my eyes are red, are really the tip of the iceberg. And the 90% that you don't see are the ones who will not persist with your treatment. And those are the ones that you need to bring back into your clinical practice by finding something that works for them better. Now, if you look at all of the prostaglandins, and here I have a comparative between tafluprost and latanoprost, because those are the ones that are the lowest on the side effect profile spectrum. The mean IOP lowering effects are comparable in all patients of glaucoma, whether POAG or ocular hypertension, and in the real world also angle closure. So why do response rates then vary between prostaglandins, even though all of them have the same efficacy at the end? That's because of the varying pharmacological structures of the prostaglandin analogs. There is a difference in corneal permeability of each of the prostaglandins, as well as the intraocular drug metabolism. Also, the differences in affinities to the prostaglandin receptors also contribute to this. Some patients are refractory to one prostaglandin, but will respond to another, which is why it is critical to remember to shift within class of prostaglandins in case of a non-response before you move on to a second line of therapy. And what then is a long-term experience in terms of long-term IOP control and visual stability when we look at all of these drugs that we have with us? Remember, eyes with IOP fluctuation of more than 3 millimeters of mercury have a significant visual field progression as documented by subset analysis. This is post-hoc analysis, but still valid. And each millimeter of IOP actually increases the risk of visual field progression. Now, what is important to remember here is the cost of 1 millimeter of mercury reduction in terms of not only the absolute cost to the patient and the economics of it, but more specifically, the cost of 1 millimeter reduction of IOP in terms of the quality of life costs to the patient. So if your decrease of 2 millimeters of mercury in a particular patient gives him a red eye and puts him at risk of stopping glaucoma therapy, is that what you should be looking at? Remember, long-term IOP fluctuation is an independent and stronger predictor than mean IOP for visual field progression. And that means that any patient who's stopping therapy in the middle, for whatever reasons, discontinuing therapy, is going to be more at risk for visual loss than any other. This is basically to emphasize why timolol is losing the glaucoma battle for us in so many ways. 24-hour IOP control is critical to managing your visual fields, and that is something we've known for a while now. And a shift to a 24-hour monitoring versus a single IOP reading monitoring is also critical to understanding your patient. The number of times you record your IOP increases your spectrum of understanding in terms of what is really happening to your patient. A diagonal variation may not always be possible. And so multiple IOP records at different time points may just tell you what is happening on the patient. A water drinking test may also give you a better indication of peak IOP levels. And multiple IOP readings are definitely superior of the IOP levels as compared to solitary reading in the office. And if you can't, do multiple IOP readings because of whatever logistics of your practice, then at least ask the patients to come at different time points once you've established the primary baseline with at least 3 IOP readings for that particular patient. Having more than a single IOP reading in a day clarifies the extent of IOP fluctuations during the examination period and also helps you identify the time of day when peak IOP occurs. Remember, all of this is usually after IOP hours, and so many times we see our patients who have been absolutely well controlled during office hours, but they do not seem to be doing well when you look at their visual fields, and which is when an evaluation of their 24-hour IOP profile becomes extremely important. For this particular patient, and this is an old patient from when I was younger, I think, you look at this particular patient, and this patient is 73 with progressive visual fields. We're happy with the kind of IOP reduction we've seen during office hours. The patient is on alpha adrenergics and beta blockers, and you would expect something similar to happen at night, but this is what happens. Remember, alpha adrenergics and beta blockers do not both work at night. There's a severe drop in their efficacy, and this could very well be the reason why your particular patient, even though your office hour control shows good reasons, would actually end up showing progression. I'm also going to show you my results with prostaglandins. We tend to believe that that there will be no nighttime rise with prostaglandins. That is not how it is. I'm not glaucomatous, the 3 panelists today, but all of us, if we were to be checked on a diagonal variation curve, and I've had one done on my eye, we would all have a physiological nocturnal rise in eye pressure. And that rise in eye pressure is blunted by prostaglandins. It cannot be removed because that's physiology. There will also be patients who will not respond to prostaglandins in terms of nighttime rise. And when they continue to progress, the only way to pick it up and attribute it to IOP and not something else would be if you were to do a diagonal pressure curve. Remember, angle closure glaucoma is no different from BOAG when it comes to IOP fluctuation. And DV is just as important in post-LPI in patients with angle closure, because these are susceptible to a faster progression rate than open angle glaucoma patients. And peak outside of IOP hours are more than half the patients, definitely, almost 70% of patients will actually show a peak IOP at 4 a.m., a time when none of us want to wake up to measure eye pressures for our patients. And then I'm going to come to the crux of what I'm supposed to talk of, the quality of life. When you're looking at the bigger concern of blindness, remember almost 30% of patients with hyperemia will discontinue their medication. They just will not be able to start. It is very, very difficult to walk around with red eyes, especially in times of COVID when people immediately ask you what is wrong or if you're drunk. Also, remember 50% of glaucoma patients have an associated ocular surface disease, and you're modifying your treatment protocol by simply adding on a lubricant means patients will use the lubricant more than they use their glaucoma medication until the communication from your side has been absolutely clear that one drug is for your glaucoma and the other drug is merely to help you feel more comfortable. In prostaglandin-treated patients, 60% switch their regimens and almost 30% discontinue their medication. And recognition and treatment of OSD is actually the one defining factor when it comes to influencing adherence and consequently the glaucoma treatment outcomes. Remember, DOPs will not work in a patient if the patient doesn't use them. And there is a high early dropout ratio, irrespective of the drug you choose, which is attributable to both the treatment and the disease per se. And it is this subset of patients that you really must identify. So patient cooperation, of course, is extremely important, which is where communication becomes the lodestone, the cornerstone of glaucoma therapy. Adherence and persistence are both crucial, and adherence and persistence depend on both you and the patient being happy with the IOP control. You in terms of the quality of IOP reduction and the patient in terms of the quality of life impact of the patient. Also remember 40% of your patients will be unable to put drops without assistance, especially those who are elderly, and you must be able to recognize this non-compliance as well. So what then have I spoken of today? The primary concern is treat the patient and not the IOP. Everyone has been harping on this now for the longest. Assess the patient as a whole, individualize the treatment, document your findings, communicate with the patient, document the communication, and then go ahead with what you're going to do. Treatment should provide effective IOP reduction. It relies on patient cooperation, and therefore safety and tolerability are just as important for efficacy outcomes as what you see in terms of IOP control, because treatment effectiveness depends on patient acceptance, and that is critical to the optimal management of disease. The holistic approach, therefore, has to be tough on IOP, easy on the eye. Remember, IOP mean reduction, 24-hour reduction, stable visual fields, safety, tolerability, patient adherence. And what I always say is Lord Hutchinson's prayer, science, compassion, together for clinical outcomes. Thank you so much for your patient hearing. It's been a pleasure to be here this Sunday morning, talking of what I love best. Rani.
Thank you, Shibal, for so elegantly telling us about holistic management of IOP. And there's definite food for thought there, which we'll take up a little bit more in the discussion section. It's a pleasure now to ask Dr. Vanitha to speak to us about tafluprost and what it adds to how it adds to our patient management.
Well, thank you very much. After that really lucid talk and, looking beyond IOP as well as holistic management, my task actually becomes much, much simpler. I'm going to talk about whether tafluprost is a value add in the medical management of glaucoma. These are my disclosures. So, tafluprost is another PG analog, and quite often I get this question because it's the same mode of action by increasing outflow through the uveoscleral pathway. Do we really need another one? By the way, the trabecular outflow, I feel the function is a little ambiguous. I feel it's not proven. So yes, this question occurs repeatedly. Do we need another PG analog? Please note that the BAK concentration or the benzyl ammonium chloride concentration is a lot less compared to other available. And we'll come to that in a minute. Leading brand prostaglandin analogs. So just stepping back a little bit and perhaps summarizing what Shibal has been saying, what are the desirable characteristics of an anti-glaucoma medication? Is of course reduction of IOP, and it should be comparable to the current gold standard. And when we're talking about gold standard, we're no longer only talking about beta blockers. We're talking about prostaglandin analogs. They should have long-term IOP control and 24-hour IOP control with minimum dosing and preservation of visual fields, and effective in all or most etiologies of glaucoma. And effective when administered not only in treatment naive eyes which have not received any medication before, but also when you're switching as well as add-on therapies. Where safety and tolerability is concerned, it has to be gentle to the ocular surface. Remember, Shibal told you they are asymptomatic. I mean, it is reiterated again and again. They are asymptomatic patients, and in case they have side effects, you are actually giving them a symptom. Okay, should not have any serious side effects equally, minimal systemic side effects. So you know that in the older age group, your beta blockers can do that. So therefore, what I'm trying to say that a balance has to be reached between efficacy and safety to help control glaucoma by least interference in the patient's quality of life. And this is what ensures persistence and adherence. Again, a concept that Shibal talked about very eloquently. So where tafluprost is concerned, it actually came into the market pretty early, 2012, but we didn't get the benefit of this drug until 2019. And approvals were granted based on several clinical trials. I picked up two. One where a 24-month phase 3 trial was done on over 530 patients, and it established non-inferiority of tafluprost, and the rate of hyperemia was much less. On the other hand, there was another one which pitted it against the beta blocker. Again, it turned out trumps. So just a brief concept about the studies that have been done, which have proven the efficacy and also safety of tafluprost. This first one tells you that there is effective 24-hour IOP control. This occurred over every single time point that the IOP was measured. There was a blunting of the maximum IOP, minimum IOP, mean diurnal IOP, and range of variation of diurnal IOP. Please remember, diurnal IOP is extremely important. Fluctuation is extremely important. And IOP lowering effect was not very different to the existing PG analogs, travoprost and latanoprost. And what's more, a long-term IOP lowering study that was done over 4,000 eyes and over 2 years found that it was effective in most etiologies of glaucoma, at least the primary etiologies of glaucoma. And adverse reactions did occur in about 18% individuals, and this was not very different from what you expect in PG analogs, including eyelash changes, hypertrichosis, and iris or even periocular hyperpigmentation. Okay, then tafluprost also demonstrated very effective IOP lowering, in all three categories of treatment naive, switch therapy, as well as add-on therapies in eyes that it was administered. But we're all worried about this kind of an appearance of a patient. Remember, the patient comes with you with white eyes, and you give this to the patient. Not only is the patient worried, but all his caregivers, his friends, his family are worried. So what is it? Is it the molecule, or is it the back concentration, BKC concentration, that matters. Remembering that tafluprost has 0.001% of BKC. Leading brands of latanoprost and bimatoprost have 0.02, and travoprost at the moment does not have BKC. And I'm talking about the leading brands. Okay, there was a study that was done, and a special software was devised to binarize the digital images that were captured of the conjunctiva, bulbar conjunctiva, to look for hyperemia, and automatically calculated. And patients who were using tafluprost experienced significantly lower levels of conjunctival hyperemia compared to other prostaglandin analogs. So here we are. I'm showing you a few more examples here in this JOAG patient. Now, he's a young patient, but tends to look much older, and that is because of this loss of orbital fat. So you tend to get an orbitopathy. The left eye is still red, right eye less so, because now he's had surgery. You can see there are some signs of surgery still there. This is only 2-3 weeks post-op. But you can see the significant change once the prostaglandin analog, particular type, was stopped in this gentleman's eyes. You can see the deep sulcus, you can see the loss of orbital fat, both sides, you can see the hyperpigmentation, you can see the hypertrichosis. And it's not just this that I'm worried about with certain side effects of prostaglandin analogs. It's also, this is yet another JOAG patient, and you can see that in his 30s, this young gentleman, I'm not able to pull his lids down. So there is tightening, cicatrization also that takes place in these, as a side effect in these eyes. So deep upper eyelid sulcus, or dews as it is called. And here, of course, because the studies were done in Oriental race, you may not, what should I say? Agree with what you see in Indian eyes, but I've just shown you these examples where you see that the same effect takes place in a different way. Look at this young lady, very smart. She was, when she first came to me, she was a student at ISB, and yet with the use of prostaglandin analog, she looks way beyond her 23 years. She discontinued all anti-glaucoma medication in the left eye, where you can see she's got a squint as well because of poor vision. But the changes are not that different. You see, they don't reverse. This is 4 years after her cataract surgery, trabeculectomy filtration surgery in the left eye. So tafluprost, saflotan, was launched in 2019. I had the privilege of being a part of that team. And since then, of course, we've had 2 waves of pandemic. So there have been lots of issues related to its availability, unfortunately, especially in tier 2, tier 3 cities. And so, WhatsApp consultations, video consultations, telemedicine, whatever you want to say it, I've had to reverse quite a few tafluprost applications to other prostaglandin analogs. Yet I do have fair amount of data. I want to present it to you. It is by no means a clinical trial. It is what we call real world experience. So here I have 44 eyes, and I have deliberately only chosen those that had more than 6 months of follow-up. And not only that, I looked at only the ones that were administered in treatment naive eyes or switch. When you add on, things become a little bit more messy. And so I have deliberately left those eyes out of this particular analysis. So I had 23 treatment naive eyes, and they have a mean follow-up of above 8 months, and a switch for 21 eyes. Sorry, not 21, 23 eyes. So intra-class PGA, switch was occurred in 8 eyes. A fixed drug combination of beta blocker and alpha adrenergic, another 8 eyes, and alpha adrenergic and carbonic anhydrase inhibitor 3, alpha adrenergic alone 2. These were the reasons for switch: inadequate IOP control, or red irritable eyes, or a combination of both, as well as a few where I wanted to change over to a single agent. So let's have a look at the etiology, and overriding is open angle disease with POAG, NTG accounting for greater than 50%. Where the total number of eyes is concerned, the maximum IOP untreated, maximum IOP recorded was 20.5. That was in treatment naive, but where the switch was taking place, obviously it was the maximum treated IOP. Post saflotan, this came down to 15.8 and a percentage decrease of 23. That this is both considering treatment naive as well as switch eyes. When you look at treatment naive eyes as a separate analysis, you can see that the maximum IOP was a little bit higher, and I achieved 34% decrease in IOP. When switch was concerned, the percentage decrease was in addition to what was already took place with the medication that the patient was on before. And as you can see, all of this was statistically significant. So just to summarize the treatment naive eyes, sorry, again, because I added another 2 eyes, the slide does not reflect that, but the decrease was by 34%, and all reported comfort with eye drops. And I did ask leading questions, and I had to, because I wanted to know about side effects, and I did not detect any significant hyperemia. Where switch is concerned, I got additional 22% decrease, and all reported either comfort or a decrease in the use of lubricants. Adverse events, 3 eyes reported kajal-like, not 3 eyes, sorry, 3 patients reported kajal-like darkening of the lower eyelid margin, but there was no complaint of increased hyperemia. All 3 patients declined photographs, so I can't show it to you, I'm really sorry. However, all reported comfort and or decrease in use of lubricants, and there was no withdrawal of the drug due to side effects. And withdrawal, as I was telling you, was only in the form of unavoidable switch due to non-availability of the drug, especially during the 2 very troublesome phases of the pandemic that we are going through. So I'd like to share with you 3 cases which I feel tend to emphasize the balance that we need to achieve, and how we can manage these glaucoma patients. A rather disturbing case this was for me. A 50-year-old gentleman who underwent clear lens extraction elsewhere 2 years ago, and at the time had 20/20 vision. This is documented, but was complaining of deteriorating vision. When the patient went back to the treating hospital, prostaglandin analog was started, but he complained of hyperemia and irritation. And when he came to me, presented to me, the pressure was 18 and 17 on an average CCT. Now remember, he underwent clear lens extraction due to high myopia. And so an average CCT is very useful. At least he does not have thin cornea. And of course, he had open angles. And when you look at the fundus, you can see the very cuptus, which was probably missed. Also, the chorioretinal atrophy, which is very common in myopia. So this was his visual field in February 2019, done elsewhere when PGA was commenced. And you can see that the right, as you noted, the right disc was more cupped, and the right visual field was affected much more. And when you looked at 10-2, it was quite worrisome. When he came to me, these were the fields. They looked much worse in October 2019, when he had a pressure of 18 and 70 on the prostaglandin analog. And his untreated maximum IOP was 19 and 21 on an average CCT, as I told you. So here now we still have 20/20 vision, but obviously he's complaining about the quality of that vision because his peripheral visual field is way, way worse, as you can see with the central 10-2 there. So here is when I switched him to Saflotan, and I took his pressure different times of the day, and I found it not going beyond 15 millimeter mercury. Here we are, his visual field. About a year later, you can see that it looks slightly better, or I don't think visual fields get better. He's definitely stable, and he's happy in the sense that he has the confidence now that things will probably not worsen from here on. His IOP continues to be stable at 2 years. He's a little bit reluctant to have visual fields done in this pandemic, so we are waiting for a repeat visual field. Here's another case of a 75-year-old pseudophakic general physician now. He has known hundreds of allergies. He had red eyes with difficulty in reading, so he was initially diagnosed as conjunctivitis and was started on antibiotics and lubricants, and quite a few of them. But he complained of increased redness, watering, and difficulty in reading. Subsequently, he was diagnosed as glaucoma before he came to me, and his untreated maximum IOP was 22 and 32 with an average CCT. He was put on Simbrinza, which is a combination of alpha-adrenergic and brinzolamide, and he used it only for 4 days when he presented to me. His visual fields looked something like this. The glaucoma was much more advanced in the eye that had higher IOP. And on presentation, his visual acuity was 20/30 and 20/40. And his pressures were 19 and 21 on the medication that he was on. He was so upset and so much in anguish that I could not suggest taking a photograph at that time, but these are my clinical notes that not only did he have quite significant congestion, but he also had follicles, and his discs, they did correlate with the visual fields that we saw. So my diagnosis at the stage was an open angle glaucoma. Whether it was pseudophakic or open angle, is immaterial. And I wondered whether he was actually having BAK allergy. So I discontinued everything and put him on Saflotan S. For those who are unaware or do not know what Saflotan S is, it is basically a preservative-free, completely preservative-free formulation, which comes in units in a pack, which has 30 units, 10 each, 3 packs of 10 each. You need to tear one off, open the top, and apply the medication. It's pretty simple. You do have to put it in, store it as in the refrigerator. So this is when he came back, and you can see he still had hyperemia. He still had follicles, but a week later, it was a lot better. I would say he was 75% better, and his intraocular pressure too was a lot better, 12 and 15 in the right and left eye. And when he was put on Saflotan S, he improved much quicker. So this is how he looks, or looked a few weeks later. You can see that the eyes are much less red. So with this patient, his last visit, IOP was 11 and 15. His complaints of increased redness, watering, and difficulty in reading. The only bits that I could sort out was the redness and watering. Unfortunately, I could not change make a difference in difficulty in reading because that was related to his glaucoma. I will quickly share one more case with you, and this is I was very concerned about this patient too. He currently is 25 years old, from Bengal, but he was given steroids for red eyes in the past, and he had advanced uncontrolled glaucoma, and I think he had JOAG as well, and he had TRAB MMC elsewhere. And when he presented to me, he had scarred blebs. And he presented 9 years ago with a vision of count fingers 2 meters and 20/100. In the left eye, he had very advanced glaucoma, and RD and lens aspiration was done, and he was controlled rising. So we started him on medication. In the right, transferal cyclophotocoagulation was done, and for a few months he was told, but he started to he was keen to pursue the same in his right eye. He was now an independent person, was working, and he was not dependent on his dad for funding him. So we planned for surgery. But he started complaining intense itching on the current medication. He sent me these photographs in the first pandemic. This is how he looked in April 2020. Obviously, it was a teleconsult. So we stopped the alpha adrenergic and continued the rest, but unfortunately, it did not change much. So it was likely alpha adrenergic allergy, but soon his pressure went out of control, and we start, just groping at things. I started pilocarpine. The symptoms improved, but unfortunately, the pressure did not, and Diamox was added, and pressure at this time was 30 and 12. Symptoms worsened yet again, and I suggested Lotipred because I was worried about steroid response also, and diagnosed that there was possibly a back allergy. And you can see a very horrifying 54 pressure in the right eye. I suggested a lens aspiration in the right eye with drainage device. He was not keen because of the pandemic and wanted to repeat TSCPC. So he traveled in late August. Again, he had red, itchy eyes. His vision had dropped in both eyes. 36 pressure in the right, 18 in the left, and this is how he looked. Not in June, well, this was actually teleconsult, but on recent presentation, that was his other eye. So all topical medication was discontinued, and he was put on maximum dose of Diamox. I did a lens aspiration with IOL and TSCPC again. It was extremely painful for him this time for whatever reason, although he'd undergone before. And I put him on Saflotan S. And in September 2020, his vision was count fingers 20/100, pressure was 24 and 18. And this is the last photograph he sent me, November 2020. Locally in May 2021, his vision was count fingers 2 meters and 20/80 in the left eye. So I was happy that his vision had improved. His pressure was 15 and 17 on Saflotan S. And in the right eye, locally, he was started on brinzolamide and beta blocker, although I had sent him off on BKC-free brinzolamide that alone did not control pressure in the right eye. So I will end by summarizing, and it did take a minute or two extra, is that there is proven IOP lowering efficacy over 24 hours. And this is similar to other prostaglandin analogs where tafluprost is concerned. There is superior safety and tolerability to other PGAs. And the preservative-free Saflotan S should be used in severe ocular surface disease or back allergy. And all above factors should result in treatment persistence and patient adherence. And you need to watch the space for future developments. Thank you very much. And I'm indeed very sorry for taking a few extra minutes.
Thank you, Dr. Vanita. I think some of those examples that you showed are not as infrequent as we would like them to be. We do see patients with these side effects, and I think it's important that everybody recognizes that these are not unusual problems. So we have time for panel discussion now. We'll see whether we have questions from the audience. While those are coming through, let me just ask you, Dr. Vanita. When you're looking at glaucoma diagnosis, comparing a glaucoma specialist with, let's say, a general ophthalmologist, what are the things that you think a general ophthalmologist needs to pay more attention to based on the patients that you have been seen by them, started on treatment and come to you?
Well, you said it all. I mean, where the diagnosis is concerned, I think a lot of emphasis is paid on the intraocular pressure itself. And if it is not high, I do not think the disc evaluation is given much emphasis on. Gonioscopy is virtually not done, or if it is done, I feel that the interpretation is incorrect. Because it's being done infrequently. The reason the interpretation is incorrect is because you don't know what is, what could be normal and what is abnormal. In my opinion, gonioscopy is one of the most difficult clinical examinations that we learn during medical school, but we should be learning it during medical school itself. When we're talking about medical school, I mean when you're doing ophthalmology. And so there is this tendency of overemphasizing a CD ratio, which again, I am very grateful to you that you have said that CD ratio should not actually come into the evaluation of an optic disc at all. Even if it is, it should be relegated to a secondary position. We should be talking about qualitative changes. And when that happens, then when they are diagnosing, I think there is an overdiagnosis based on CD ratio itself. There are so many, cases, and a major part of, I'm sure, all of our work is to reverse the diagnosis of glaucoma that has been made on a large physiological cup. They counsel the patients very well. They will tell them, you have to continue this medication for a lifetime. You can't stop. Doesn't matter who tells you to stop. Do not stop. All those things are fine. But unfortunately, you have to get to the diagnosis also correctly. You cannot put a tag on a patient saying you're glaucoma and you will go blind if you don't take your medication. Having said that, the other thing that is not done is a functional evaluation. They may look at the CD ratio and diagnose based on OCT also, because they see, some red somewhere. But there is no clinical correlation. The clinical correlation is extremely important. How you pick up the changes in the rim and the changes in the RNFL, along with the other features, is so important. And having said that, the other thing that happens is that when they start treatment, then they start with, I think giving cost the biggest, the highest criterion for choosing, and choose a beta blocker. And what happens is, if you're not looking at the patient holistically, where a patient, an elderly patient, whether they have heart disease, whether they have chest disease, whether they have asthma, all that is not being taken into consideration. And mind you, there are several who are coming back with long COVID now, who could be actually worse on beta blockers. We don't think about these things. And also in the young, I don't like giving beta blockers in the young. I mean, they are a sexually active group, and you are possibly reducing their libido. So, beta blockers, we need to have a change in mindset that if we are actually diagnosing glaucoma correctly, then we really need to switch to a class of drugs that give long-term IOP control, 24-hour IOP control, and with minimal dosing, so that we don't have don't have issues of quality of life, which is very important, because that is what results in adherence and persistence. That is my take on it.
Excellent. Shibal, would you like to add something to this, specifically once it comes to how IOPs are also measured?
I mean, all kinds of instruments being used, and the applanation tonometer has, for some reason, lost favor with most of our colleagues. Also, glaucoma specialists who use the NCT to monitor glaucoma. It's a tough one to fight in a busy OPD, but that is the basic minimum. My pet peeve, which bugs me beyond belief in the glaucoma clinic, is people who write cornea-corrected IOPs. It completely drives me bananas when people have fellowships in glaucoma to their name and they are still correcting for IOP. I've had presentations I have seen in GSI on AIOS day before yesterday, and then there was somebody who's talking. I was like, no, you do not correct for the corneal thickness on IOP anymore. All you know is that thinner corneas require more attention than thicker corneas. And if you're that worried about hysteresis, invest in a DCT. I think that's what bugs me most. And also, and unlike Vanita, who's seen more patients who've been counseled, I have come across patients who doctors don't speak with. Also, absolutely empty examination findings.
Yeah.
No diagnosis, just a little scribble saying what drug to use. And it just drives you nuts. You didn't know what the patient had 4 months ago, and you have serious glaucoma specialists also doing it. So, and pardon my French, but this is completely unacceptable. You cannot presume that the patient will forever stick to your practice. The patient will go outside, and handing over patient records is so critical. I think those are my two big issues when I see patients from outside.
So I'm going to switch gears a little bit and then ask you, in your experience, do you see big differences in clinical efficacy between the 4 prostaglandins?
Not really, but I mean, this is a Santan symposium, so I'm going to still not mince words. I do think bimatoprost and travoprost would be on the more effective side, and tafluprost as well as Zalatan are going to be, latanoprost, I'm sorry, no brands, are going to be on the lesser effective side. But these millimeters of mercury are very few, and they really do not impact clinical outcomes beyond driving you bananas, but that you know that it's not 16, because in my mind, the target IOP was 16. As long as you are putting a range to your target IOP, I think all prostaglandins are the same. Just a little bit of a left to right fluctuation.
From the side effect point of view?
Side effect point of view, it's dramatic. Side effect point of view is dramatic. I think travoprost would be middle of the spectrum, and latanoprost and tafluprost would be much superior side effect wise. Even the 0.01, because it has an increased concentration of back, I think, even though you don't end up with the dramatic red eyes of 0.03 bimatoprost, because of the increased back concentration, over time, you will see changes in the conjunctiva. I think we are perpetrating an epidemic with OSD, and completely as glaucoma specialists. So these are softer drugs. That is beyond question.
No, that's actually an interesting point that you raised, because I had a patient who, for the last 5 years, has been complaining of watery eyes and difficulty reading and whatnot. And anyway, we had no option but to operate on him, and he came to me 3 months post-surgery, and I had to ask him, I'm perfectly comfortable, I'm not used to lubricant, there's nothing going on.
But I have 2 patients with bleb dysplasia, and never in my life would I want that, because there really is nothing you can do then. I mean, I have thought of cauterizing and all kinds of things, but it's scary as sin, so I haven't touched them. So those are the 2 patients that give me nightmares. So I completely believe.
I showed the picture of 2 JOAG patients. The one with the cicatrizing change, I did do a trabeculectomy with mitomycin C in both eyes. The right eye settled very well, but the left eye developed a huge conjunctival, what should I say? It was thinning first and then completely de-epithelialized. And it was leaking profusely from there. And, I did a needling, tried to direct it elsewhere, the aqueous elsewhere. Nothing worked, but I put a BCL on him and gave him cyclin, and it worked. But it took several months to settle down. The reason I didn't take him back to correct that, because the area was really rather large. I felt putting any suture in there would just cause cheese wiring, and I would end up with a greater problem, and maybe use, then use conjunctival autograft and things like that. And the patient was just not interested in all that kind of management. Needling, of course, I do on the slit lamp, so it's not such a big deal for me. But you can have these kind of trouble because of surface problems. His eyes were never red, but he did have this problem.
So one of the other things that, one of the side effects that you spoke about, I'll just ask Shibal. There seems to be a feeling that in North India, we don't see as much of dews. The deepening of the upper eyelid sulcus, as has been reported from
It's also to do with the fact that our eye, look at my eyes, is sunken. It's also to do with the fact that that's how we are made, shallower orbits towards the east. So our patients from the east of India, especially the northeast, would have a much higher incidence. But we do have a lot of deepening of the superior sulcus. It just takes forever. So younger practices may not notice it. People who have not been on the prostaglandin for so long may not notice it, because I do believe it is also dose dependent. You want to have it in 3 weeks. So the longer the practices, the longer the patient you follow up. Dews has been something that has been newly recognized for us, I think, because cosmesis is the last thing on our mind when we are treating glaucoma. We're just so focused on everything. But now that we are talking about dews, I think I'm recognizing it more and more in my practice.
That is the case.
I agree, because unless you're looking for it, you won't find it.
Yeah.
We went through it for years.
That's precisely where it is right now. Just as if you don't elicit a history of irritation, half the time the patient is not going to tell you. If you do not ask for a QL questionnaire or an OSD questionnaire in your practice, you are not going to elicit a lot of OSD, because what you see is really the tip of the iceberg. And
so what about hyperpigmentation, periorbital hyperpigmentation? Have you had to stop any patient?
Yeah, a couple of them, yes. A couple of them. One was, again, is it parochial to say Maharashtrian lady with green eyes? So I stopped that. She had beautiful eyes, and I was like extremely in two minds. And I was like, listen, let's talk this through. And do we want to do 2 drops instead of 1? And then she said, yes, but I would like to keep my green eyes. Pigmentation, I think the elderly are more accepting of the fact that they will have a lot of pigmentation. I think what has really dramatically improved outcomes for me is the fact that I always encourage them to use a tissue, and to always put the tissue here before they put in the eye drop, and not use their finger to pull down the eyelid, but just the tissue paper. Wiping off excess actually helps. Hypertrichosis means I have treated unilateral glaucoma both eyes. I have done that in my practice as as more the rule than the exception.
Ladies, gentlemen have not complained. So
yeah, we hope that is how it is.
I also suggest using a little bit of, say, moisturizer or a little bit of coconut oil on your lower lid before you apply the drops, if they are complaining. But some of them, they come back with a complaint. The kajal, like as I was telling you, they complained about it, and I said, were you doing what I suggested you to do? And they said no. So I said, please try it.
And this is something that is common to most prostaglandins, and we see it less with tafluprost than we do with the other 2. And I think we need to be aware that there is much more than hyperemia when it comes to prostaglandins. Mm-hmm. There are other side effects that we need to be aware of and that we need to look for.
I think the mind, unless the mind knows, the eyes are not going to see. And glaucoma specialists have so many blind spots. I mean, you fixate on IOP, even visual field sometimes become a blind spot. The optic nerve definitely, and the angle is a definite blind spot for almost all of us. Just the one gonioscopy is not adequate. You do need to repeat it over time because the angle changes. And that, plus the fact that we're not looking for side effects. I think the eye doesn't see what the mind doesn't know. For me, it has been true for years. So until we started talking about it, I didn't look for it and I didn't see it.
So in addition to looking at the patient closely at the slit lamp, we need to step back a little bit and take a look at
the patient as well.
Sorry to interrupt you, doctors, but we are just left with 1 minute. So we have to wind up the session within 1 minute. Thank you.
There is a question, Dr. Rani. If we see a patient with occludable angle opening with mini pressure without pass and average CCT with normal IOP, Dish showing changes, how to categorize and treat.
Why didn't you take that?
I just read out the question. Hang on, let me just read that question all over again. Normal disc is showing changes. You have to do a visual field and then look at your mini pressure. If it is an occludable angle, will you not consider this will step into the realm of primary angle occlusion glaucoma, because you're looking at disc changes already and you're looking at an angle that is occludable. You will consider a PAC, do a visual field to see what is happening, and then we take it forward from there.
So this suspect with a
occludable angles.
Visual field is very important.
Just wind up because we're down to 20 seconds. So thank you, Shibal and Vanita, for a lovely session and for a very interactive panel discussion. And thanks, Santin, for the meeting and the AIOS for letting us do this. So Surabhi, over to you. I think we are finishing on time. Is that okay?
Thank you. Thank you so much, sir. Thank you all the